Good morning, everyone. My topic for today is a baseball bat sign predicting the prevalence of intraop floppy iris syndrome in patients on tamsulosin. I have no financial interests. So what we already know is that benign prostatic hyperplasia is a common condition in elderly males with a very high prevalence as you go higher in the age group. We also know that the treatment of the same is in the form of giving alpha blockers, which helps to relax the smooth muscle of the prostate. But the side effect of the same is that it acts on the receptors on the dilator pupillae. Now, it is very well documented that when the alpha adrenergic drugs act on these, it causes something called as IFIS or intraoperative floppy iris syndrome, as Dr. Chang has already published. It mainly consists of insufficient pupillary dilation, undulated or billowing of the iris prolapsing into the wounds, and progressive intraop pupillary constriction. But we do not know what exactly is the incidence of IFIS in patients on tamsulosin. Various different studies have published different percentages of this. So our research question was that is there a perfect method to predict the occurrence of IFIS in patients on tamsulosin? My material method was a case control study. The sample size, a test group that was a patients on tamsulosin greater than 3 months was 76 eyes, and a control group of 76 eyes and patients not on tamsulosin. Age was above 55 years old, male patients only. No other drugs besides tamsulosin was considered. Glaucomatous patients on AGM and complicated cataracts, and any patients who had altered iris morphology were excluded from my study. Besides the routine preoperative examination, we made the patient undergo an undilated anterior segment OCT and an infrared pupillometry. So from the OCT, what we actually assessed is the iris structure and pattern, and using the pupillometry, we assessed the pupillary diameter under both photopic and scotopic lighting. Now, this is the iris measurements. Here you see the scleral spur and the pupillary margin. Exactly midway between the two is the dilator muscle region, and 0.75 millimeters away from the pupillary rough or the pupillary margin is the sphincter muscle region. So, and we also did the pupil measurements using both photopic and scotopic pupil using the correct lighting conditions. Now, we also then checked for the incidence of IFIS intraoperatively while the surgeon operated in all the cases. So, what were the results of our study? There was no age differentiation between the two groups, but we did see a significant decrease in the dilator muscle region thickness in the test group as compared to the control group. There was no significant difference in the thickness of the sphincter muscle region area, and there was an altered DMRT versus SMRT ratio. Now, this is the thing in the control group, as we see here, the dilator muscle and the sphincter muscle region area thickness is more or less similar, whereas in the test group, the dilator muscle region thickness is almost 0.75% less than the sphincter muscle region thickness. These are the photographs of different patients of the same. So because of the striking resemblance of the iris of these patients on tamsulosin, we coined the term as a baseball bat sign. There were also marked differentiation. That means there was decreased photopic pupil size in the test group as compared to the control group. The scotopic pupil size also was markedly reduced as in the test group as the control group, but there was no difference in the ratio between the photopic and the scotopic pupil. Now, how did this correlate intraoperatively? In the control group, none of the patients developed any signs of IFIS. In the test group, 62 of the 76 patients had one of the signs of the IFIS at least, that is either floppy iris prolapsing into the wounds, or an intraoperative pupillary constriction. So what is the conclusion of my study? A use of the baseball bat sign, that is the thinning of the DMR thickness of the iris on the anterior segment OCT, is a reliable tool to detect the occurrence of IFIS in patients on tamsulosin. So what new does our study add? It uses anterior segment OCT for predicting the occurrence of IFIS on patients on tamsulosin. It's the first study to demonstrate the thinning of the iris DMR in patients on tamsulosin, and we hence coined the term the baseball sign. And it also demonstrates inadequate pupillary dilation in patients on tamsulosin using infrared pupillometry. So how do we translate this science to our clinics? We would be better prepared if we knew preoperatively that patients are going to be suffering from IFIS. We would create longer wounds, do a more controlled hydrodissection, decompress the chamber repeatedly to remove out the viscoelastic, and do a low-flow phaco too. What is the futuristic approach to overcome the limitations of my study? Now we need to find a method how to correlate the iris measurements which we've got from the anterior segment OCT into the real iris thickness, and if we could do human cadaveric studies to corroborate the iris dilator muscle region smooth muscle tone deficiency in patients on tamsulosin. Thank you.
Thank you, Nitin. Wonderful presentation. Dr. Sri Ganesh, please.
Yeah. Nice presentation. I just wanted to know how many of these patients were diabetic?
So we did not consider any of the systemic conditions here as hypertension or diabetes as a deciding factor, as in we did not take that into consideration. They were equally distributed in both the control or the test group. Diabetes was not an exclusion criteria in our study.
So you had diabetes, because
yes.
In diabetes also you can have inadequate pupillary dilatation, you can have glycogen deposition in the iris, and so this can affect the thickness. So
yes.
That is a confounding factor in the study.
Correct.
You should probably exclude diabetic patients. And intraoperatively, did you use adrenaline and xylocaine in these patients?
So the surgeon was not informed about what kind of, this was a retrospectively, we went back and checked that what was the percentage of patients who had both the baseball bat sign and the IFIS symptom. Intraoperatively, the surgeon wasn't aware whether he was operating on a patient of the test group or a control group. So he performed the phaco as in a regular case he would as a routine.
Because on scotopic pupil was 5.6
yes, sir.
In your test group. So 5.6 pupil, it's very difficult to do phaco. So the surgeon would either use adrenaline and xylocaine or use a pupil dilator.
Yes, sir.
So when you use a pupil dilator, you can't really assess the floppy iris. Or if you use adrenaline and xylocaine, then it again reduces the floppiness. So you can't really assess whether it's actually a floppy iris or not. So ideally, the surgeon should operate without any devices or pharmacological agents. And if he doesn't know, then if it's a small pupil, he will automatically, if it's 5.6 pupil, I think most of us would use either adrenaline xylocaine to try to dilate it or use a ring. So that is again a confounding factor. So this is something that you have to keep in mind.
Yes.
So these are basically the fallacies which I found.
Yes.
I would like to ask a question. You have mentioned that the dilator muscle thickness is less. So what could be the reason? Because you have done a retrospective analysis.
Correct.
And after surgery also there are effect on the dilator muscle.
Yes.
So how do you correlate that this is due to the medicine and not due to the surgery? And what could be the cause of this decreased thickness of the dilator muscle?
So ma'am, we took the measurements, the measurements were taken on the anterior segment OCT prior to the surgery. It was not taken after the surgery. So what we did is that before, as I said, pre-operatively as a part of the routine cataract investigations, we also did an anterior segment OCT where the dilator muscle region thickness was measured. And then intraoperatively, the surgeon performed surgeries routinely, and we saw what was the ratio of the patients who developed IFIS who also had the baseball bat sign. So we have not taken the post-operative anterior segment OCT to see what was the thickness in that.
That means the surgeon knew that the
no,
patient is
no, the surgeon did not know that
I was a little concerned about your definition of IFIS as well. You said any one of the three or odd features you took as IFIS.
Yes, sir.
So just the prolapse of the iris, if there is some other factor in construction of the wound or too much pressure used, you wouldn't be able to classify that as IFIS. So I think that needs a better definition.
So we have used.
Thank you, Nitin. It is well understood this thing, and wish you all the best.
Thank you, sir.
Yeah.